Two patients arrive at the hospital with extremely high blood sugar. One is breathing rapidly, acidotic, and deteriorating quickly, while the other is severely dehydrated, confused, but not acidotic. Both situations are life-threatening and both are complications of diabetes, but they are not the same condition, if that makes sense. This is the difference between diabetic ketoacidosis and hyperosmolar hyperglycemic state. That was a mouthful. During the course of this video, if you hear me say DKA and 2HS, know that I'm referring to these disease conditions. Hi, I'm Mira and you're welcome to Mira's Health Hub. Please subscribe and let's begin immediately. Thank you. At first glance, DKA and 2HS appear similar in that they present with severe hyperglycemia, dehydration, and altered mental status. But beneath the surface, the underlying physiology is fundamentally different. And to understand that difference, we need to ask one central question: what is insulin doing in each condition? In DKA, there is an absolute or near absolute insulin deficiency, but in 2HS, there is relative insulin deficiency, yet there are still small amounts of insulin present in very minimal quantities. This single distinction explains almost everything that follows afterwards. In DKA, low insulin plus high counter-regulatory hormones like glucagon and catecholamines leads to intense lipolysis, where fat is broken down into free fatty acids, transported to the liver and converted into ketones. These ketones accumulate and produce metabolic acidosis, and I spoke about it extensively in this video here. It will help you understand better. While in 2HS, there is enough insulin to suppress lipolysis, so fat breakdown is minimal. Ketone production is negligible and acidosis does not develop. This is why DKA equals ketones plus acidosis, while 2HS equals no significant ketones. So you get the difference now, right? Good. Let's proceed. In DKA, blood glucose is elevated between the range of 250 to 600 milligrams per dl, while in 2HS, glucose levels can exceed 600 to 1000 milligrams per dl. Why is it so? It's because in 2HS, there is no severe acidosis to trigger early symptoms. The condition develops more gradually and hyperglycemia continues unchecked for longer, so glucose accumulates to extreme levels. But the defining feature of 2HS is not just high glucose levels, it's hyperosmolality, a situation where an elevated concentration of solids such as glucose, in this case, is causing water to be drawn out of the body's cells, signifying a deficiency of total body water relative to solids. So as glucose rises, it increases plasma osmolality, where water shifts out of the cells, including brain cells, into the bloodstream, leading to cellular dehydration and neuronal dysfunction. Clinically, this presents as confusion, lethargy, seizures, and coma in worst-case scenarios. Neurological symptoms in DKA are more related to acidosis than extreme dehydration. The key distinctions between DKA and 2HS are as follows. DKA is defined by metabolic acidosis, while 2HS is defined by severe dehydration and hyperosmolality. In DKA, the primary problem is acid accumulation, while in 2HS, the primary problem is fluid loss and concentration of blood. DKA develops rapidly, often within hours, commonly triggered by infection, missed insulin, and new onset type 1 diabetes, while 2HS develops slowly, over days to weeks, and commonly seen in older patients with type 2 diabetes and limited access to water or impaired thirst response. And because of this slow progression, dehydration becomes profound before symptoms are even realized. In DKA, there is the Kussmaul's respiration, fruity breath or presence of acetone, and abnormal pain, and these are signs of acidosis. While in 2HS, there is extreme dehydration, dry mucous membranes, and severe neurological impairment. Note that both conditions involve total body water loss and electrolyte depletion, but in 2HS, fluid loss is typically more severe, causing higher serum concentration and greater circulatory compromise. While in DKA, electrolyte imbalance is compounded by acidosis, especially affecting potassium dynamics. Despite DKA being more dramatic, 2HS or HHS has a higher mortality rate because it affects older, vulnerable patients. It is often diagnosed later, dehydration is more severe, and comorbidities are common, but DKA is more acute in nature. In terms of treatment, both conditions require fluid replacement, insulin therapy, and electrolyte correction. But priorities differ because in DKA, the focus is on stopping ketone production and correcting acidosis, while in 2HS, focus is on aggressive fluid replacement and gradual correction of hyperosmolality. Rapid shifts in osmolality must be avoided to prevent complications like cerebral edema. For a quick summary, DKA and 2HS or HHS are not just two versions of the same condition. They are two distinct metabolic states driven by different levels of insulin activity. DKA is the state of acid production and metabolic collapse, while 2HS is a state of extreme dehydration and concentration of the blood. And understanding that difference is what allows timely prioritization and treatment of condition appropriately. If this clarified the difference between DKA and 2HS or HHS, share it with someone who wants to understand diabetes beyond high blood sugar. And for more clinically grounded breakdowns, subscribe to Mira's Health Hub. Share my content with anybody you feel that needs it. Give it a thumbs up, and I'll see you in the next episode. Until then, bye.